Hello, everyone, and thank you for joining today for this important discussion. I'm Dr. Bruce Scott, the president of the American Medical Association, and it's great to be with you today. As we prepare for the fall and winter respiratory virus season, we know that many of you and your colleagues have questions about how to best protect your patients, your families, and yourself. So before we begin, I have a few slides to review relating to the continuing education that's being offered through CDC Train. Instructions for obtaining CE, including a link to this course, will be shared at the conclusion of today's webinar. First is the accreditation statement. This webinar is accredited for CME, CNE, AAPA, CEU, CHES, MCHES, CPE, and CPH. Next, here's a slide projecting the learning objectives for today's webinar for you to review. The final slide shows the following disclosure statement from CDC. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, and contact experts wish to disclose that they and their spouses or partners have no financial interest or other relationship with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations today will not include any discussion of unlabored use of a product or a product under investigational use. CDC does not accept any commercial support. The use of product trade names in the following presentations is for identification purposes only. With that, thank you again for joining us today. We are joined today by three distinguished guests from the Centers for Disease and Control and Prevention. The Director, Dr. Mandy Cohen. The Director of the National Center for Immunization and Respiratory Disease, Dr. Demetre Daskalakis, and the Chief Medical Officer of the National Center for Immunization and Respiratory Diseases, Dr. Manisha Patel. This virtual discussion is brought to you in collaboration with Project First Line. The AMA is committed to protecting public health and the health and wellness of physicians. So we are proud to be a Project First Line partner. As we gear up for the fall and winter respiratory season, we're thrilled to have these CDC experts here with us today to share key updates and answer your questions regarding vaccination and treatment. Before I turn it over to our speakers, let me tell you a little bit about each of them. CDC Director Dr. Mandy Cohen is an internal medicine physician who began her role as a CDC Director in July 2023. She is one of the nation's top health leaders with experience leading large and complex organizations and has a proven track record protecting America's health and safety. As the Director of the CDC, she manages and directs the activities of the agency, which includes developing and applying disease prevention and control, environmental health and health promotion, and health education activities designed to improve the health of the American people, as well as other nations and international agencies. Also joining us is Dr. Demetre Daskalakis. Dr. Daskalakis is an infectious disease physician and the Director of the National Center for Immunization and Respiratory Diseases at CDC, where he leads the CDC's efforts to detect, prevent, and respond to vaccine-preventable and respiratory infectious disease threats. He oversees and coordinates activities across the center to effectively balance public health efforts in both domestic and global arenas, and to accommodate the specific needs of a variety of populations at risk for vaccine-preventable diseases across the lifespan. Dr. Daskalakis plays a key role in CDC emergency response to respiratory and vaccine-preventable diseases such as seasonal respiratory viruses, COVID-19, influenza, and RSV, measles, and avian influenza. Our last guest is Dr. Manisha Patel. Dr. Patel is a pediatric infectious disease physician who currently serves as the Chief Medical Officer for the National Center for Immunization and Respiratory Diseases. She is also a captain in the United States Public Health Services. She brings more than 15 years of leadership and technical experience in surveillance, study design, and implementation, emergency response, and vaccine policy and communication for vaccine preventable and other respiratory diseases. As CMO, she directs and oversees cross-cutting and multifunctional program activities, including NCIRD's healthcare provider strategy and outreach. Dr. Cohen, Dr. Daskalakis, and Dr. Patel, thank you for joining us today. Now I will turn it over to Dr. Cohen for some opening remarks, and then we will move to our Q&A session, which will include your pre-submitted questions as well as those submitted within the chat. Please welcome Dr. Mandy Cohen.
Well, thank you so much, Dr. Scott. Great to be here with all of you. Thanks to the AMA, thanks to First Line for hosting this important discussion. We wanted to make sure that we were getting you the best information we can, so we are all prepared as we go into the fall and winter respiratory season. Turns out that respiratory season happens every year, and we're getting better and better at being prepared as we go in. So we hope this information will be helpful to you, to your practice, to your patients, to your community. The first slide here that you see is the top information about who should get the various vaccinations in this upcoming season to protect themselves. COVID and flu are quite straightforward. Everyone 6 months or older should get the updated 2024-2025 COVID-19 vaccine and flu vaccine, including pregnant moms. So everyone should get that updated COVID-19 vaccine, the updated flu shot this year. For RSV, for infants, there are 2 options, and only one is needed to protect those infants against RSV. One option is all infants under the age of 8 months, as well as children 8 months to 19 months with risk factors should get nirsevimab, which is typically given October through March. There's also a maternal RSV vaccine, which is recommended for pregnant moms between 32 and 36 weeks gestation, and typically is given September through January. Again, moms would get that, pass on those antibodies to their children. And then for older adults, we did clarify the recommendations going into this season. So want you to pay attention to these updated recommendations, which is all adults over 75 should get an RSV vaccination. That is a one-time dose of that RSV vaccination. And adults 60 through 74 with risk factors should get a one-time lifetime dose of the RSV vaccine. Okay, let's talk about those risk factors in the next slide here. There are a number. So if you're 60 to 74, your patients are, and you want to counsel them, the top ones here are the most likely things that would put them into that higher risk category, things like heart disease, obesity, diabetes, lung disease, but there are others here. So if folks are at higher risk, make sure you are having a conversation with them about the RSV vaccine. Particularly, I want to highlight those who are in a nursing home. We are seeing more RSV circulating in nursing homes. We really want to make sure anyone who is residing in that group setting is protected from RSV going into this season. Okay, next slide. Okay, so we know who should get it. What about timing? We're going to see an updated COVID-19 and flu vaccine here in just a few weeks. Flu is actually starting to be available right now, so you can be ordering that, be getting that in to your practice already. The COVID-19 vaccine should be available within the next number of weeks, maybe the end of August, beginning of September, but right now is a great time to pre-order, and we'll have more on that soon. And then the administration should continue through September, October, November. Those are the months you really want to be paying attention to, but that's the ideal time, but doesn't mean that we couldn't keep vaccinating beyond that time as well. right now, today, if your patient walks in and is over 75, talk to them about the RSV vaccine. Those are available right now. And again, it's a one-time dose for folks. Ideally, the best time to give those RSV vaccinations are as we get into the season, particularly as we're looking at the maternal and the infant RSV immunization. Because just to clarify, the RSV immunization for infants is a monoclonal antibody. So again, we want to give that during the RSV season. It does have a limited lifespan of that protection, so we want it to overlap with the season as much as possible. So COVID vaccine available soon, then start giving those September, October, November. Flu already starting to be available. We want to ideally administer in the September, October timeframe. RSV can be doing now, or late summer, early fall. And then again, the infant and maternal a little closer to the start of RSV season and more in the late September, October timeframe here. Okay, next slide. So how do you get prepared? The first is making sure that you are, thank you for joining this webinar, and thinking about ordering and offering those immunizations, right? Thinking about pre-ordering, getting ahead. And if you're even able to identify a champion for vaccination in your office, if you haven't done that already. So that really helps to make sure your office is set up and prepared for having conversations with patients about vaccination, as well as not missing an opportunity to give out those doses. So every time someone walks in to your office is an opportunity both have that conversation and to make sure you're immunizing. And there are new tools to make that easier. So here you see on the CDC page, you can see down there, it's at vaccines and it's info by product. So if you want to get the latest on how to order Moderna, Novavax, or the Pfizer COVID-19, or on the RSV side, the GSK, Moderna, or Pfizer, all that information and details on the product type, whether it's multi or single dose vials, is all in there, as well as return policies for unused product. We know that was an issue going into last year because look, this is all new and we're sort of getting our clinics and our practices ready for this season. So this is exactly the time you want to make sure you're thinking about all of these things. Okay, next slide here is just a bit on how are we talking about vaccines overall. We continue to see lower uptake of these annual vaccines than we would like to see, but we know that they are our best defense against those serious illnesses that we know make our patients sick each and every fall and winter season. So these are some of the ways in which we wanted to share with you messages that can help cut through and help your patients understand why immunization is for them and getting vaccines. So one, understand the risk. Viruses can cause hospitalization. And we unfortunately know that hospitalization is the number one cause of it for infants is RSV. So we very much want to be making a dent there. And we know that some are at highest risk. We can't predict it all, right? That is why vaccines are such a powerful tool. So even though it's adults who are over 65 are at the most risk, we're also seeing children under the age of 18 be hospitalized with COVID-19, even if they don't have underlying conditions. This is why I'll just share personally why I plan to get my daughters who are 10 and 12, both the updated flu shot as we get recommended every year and the updated COVID-19 vaccine. It's exactly because of this reason, because we are seeing that half the children hospitalized for COVID-19 have no underlying conditions. So that's what I'm planning to do for my own family. Might be a way for you to talk about it with your patients as well. And then we know that immunizations continue to be our best defense. I am going to talk about treatment. So if someone does get sick with COVID or flu, we do have treatment, but vaccines do cut the risk of hospitalizations. RSV vaccines are 70% effective in preventing those older adults with an RSV hospitalization. And nirsevimab is 90% effective at preventing hospitalizations for our little babies. So we have effective tools and we just need to make sure we're using them. On the next slide here, we know how important you all are in making this recommendation. What we're seeing from our research, one of the major reasons someone doesn't get a vaccine is, well, my doctor didn't recommend it. It didn't come up. So I assume it's not that important for me. And so making that strong recommendation for something like a COVID vaccine or a flu shot is really, really critical. And so we put here, what could a strong recommendation? It doesn't have to be an hour-long conversation. It's just, you're due for your flu and COVID vaccines today. I've gotten these vaccines myself, and I recommend them for you too. Right, that is, the strong recommendation we'd love to see here. What we're also seeing is the reasons providers don't recommend flu or COVID vaccine is that they think that there are medical contraindications. But we want to reiterate that contraindications to these vaccines are exceptionally, exceptionally rare. Severe allergies are rare. Things like the multi-inflammatory symptom in children is incredibly rare, and myocarditis is also rare. Again, these are things that there was some myocarditis, also very rare, but it was rare in adolescents or young males. We've seen that even decrease over time, 150 in 1 million doses. And again, for MISC, that is less than 1 per 1 million vaccinated children. So these are incredibly rare, and really want to make sure that a contraindication isn't preventing you from making that strong recommendation to your patients. Next slide. And so other tools and tips for you. So you know that this takes preparation, particularly thinking ahead to your workflow in your practice. So some of this is just some tips and tricks that we've gotten in terms of best practices on how to make sure you're embedding getting vaccination into that workflow, right? Obviously, reminder calls and making sure you're using things like your clinical decision support tools. On the side of the slide here, if you're an Epic user, you may recognize this. This is your care gaps list, right? And so you can use this to be tracking to see what immunizations your patient may need. You want to also continue to make these recommendations. If someone has said in the past, nope, it's not for me, how do we turn that into an ongoing conversation? It may not have been right for them a year ago. Time to open that conversation again. So even if they've declined one time, don't make that a permanent way of them approaching vaccination. Oh, please do recommend that immunization to unvaccinated patients. Your voice matters. They trust you and your recommendation. It's what folks say over and over. And when you do recommend it, folks may not say yes in that moment, but it does go into their thinking, and they may come back the next time and be more open to it. And then making sure to close the loop with pharmacies, particularly if you are sending a patient to a pharmacy for an RSV immunization, make sure that you're including all the information that they might need in that prescription or on the after visit summary, particularly with RSV. And if someone is between that 60 and 74 age, make sure you're including those risk factors. Do they have heart disease, diabetes, obesity, some of the things that would put them at risk factors? And on the pregnancy status, making sure to include their gestational age, because again, that immunization is for folks who are pregnant between 32 and 36 weeks of pregnancy. So all of that just helps making sure that we are streamlining and prepping as we go into this season. All right, next, we can't talk about vaccinations without thinking about cost barriers, and we know that those are real for folks out there. The good news is we do have an ability to cover a lot of that cost for our children in particular. If you are not already part of the Vaccines for Children's program, we would love to have you participate. This is where we can get free vaccines to our children, COVID, flu, nirsevimab, and others, for folks who are Medicaid eligible, Medicaid enrolled, as well as under and uninsured, as well as our Native American population. So this is a really important program. So if you are not yet a Vaccine for Children provider, we would love, love, love to have you in that program. Please reach out. But know that also many of our private insurance are are required to cover these vaccines without charging a co-payment or co-insurance when they're given by an in-network provider. Medicare covers these. COVID and flu vaccines are covered by Part B, and Medicaid. ACIP recommends those vaccines are covered without cost sharing. And again, those are offered through the Vaccines for Children's program. So cost should not be a barrier in your practice to your patients, but do help facilitate this process for your practice so that you get reimbursed for the work that you are doing, both in counseling and administrating, but also to make sure we are keeping cost not being a barrier for patients, and so doing all that we can to get them the vaccines that they need. The last thing I wanted to bring up for you is a campaign that you may see us running in your neck of the woods. We are going to be able to run some paid advertisement during the season to help folks get ready and then actually motivate to action to get vaccinated. It's a campaign called Risk Less, Do More, Get This Season's Vaccines. So you are going to see some of that launch in a few weeks here. Obviously, it's not time yet to get those COVID and flu vaccines, so you're going to see more of that campaign launch in a bit, but we'll start with focusing on RSV, because if someone comes in who's over 75 right now, they can get that one dose of the RSV vaccine and they're set into the future. We are going to be working through some paid media, including TV, radio, and print. So maybe you'll see this in your neck of the woods. The audiences on the next slide that we're focused on are not going to be surprising. Who are the folks that are at highest risk and need to risk less to do more? It's older adults. Older adults and folks in long-term care facilities or our nursing home residents. We want to be making sure we're really targeting that highest risk group. So you'll see a lot of images like the one on the screen where we are making sure to have messages to our older adults, and particularly those who are in long-term care facilities. That all being said, we also want to make sure that we are recognizing that historically marginalized communities continue to see lower vaccination rates than others, and we make part of this campaign will be to reach out to all adult populations, specifically focusing on our Black, Latino, and rural audiences. And then lastly, we have a component that will be focused on you all, because we know how important a team member our clinical community is in making sure vaccination happens. So we're going to have some ability to do messaging. So you may see some ads and such, again, reiterating a lot of what we are covering today. Before I end, just two more slides here, and then we'll take your questions. Just a reminder that we've been talking about fall and winter, but we are having a fair amount of COVID circulating right now. And just a reminder that we have tools for you to know what's happening in your community, how many folks are getting admitted to the emergency room based on COVID, what are things looking like, so that you know how to potentially change or recommend things, particularly for those higher risk patients. So just know that COVID is circulating right now. It is what we are seeing is, while there is a fair amount of COVID circulating, we're seeing lower levels of emergency rooms and hospitalizations than we've seen in the past, which is good. But we want to make sure we're continuing to protect each other, particularly those folks who are at highest risk. And then the last slide here is about treatment. Most of this has been focused on what we can do to prepare, but don't forget about the fact that if someone does get sick, particularly with COVID-19, and that we have the ability to treat them. And we are seeing less use of the treatment than we would expect, given how effective the treatment is. So we do see that Paxlovid cuts that risk of hospitalizations and death, but you need to use it early. I hear a lot of folks in my personal life come back to say, well, my doctor says I'm not that sick yet, so I don't need the medicine. That's kind of the whole point, right? Is to get the medicine before you're sick, particularly if you are at higher risk. So adults who are over 65, it's really important for those folks to get on treatment if they do get COVID-19. For pregnant moms, people with weakened immune system, and again, anyone who might have underlying conditions. There is a bit of a misnomer out there that you had to do a blood draw and check liver functions or creatinine prior. You do not. So no blood draw necessary. You do want to, as all medicines, review drug-to-drug interactions and adjust dosages. But again, a really important option. Please use that particularly for adults over 65. And of course, there are alternatives there on the screen as well. So don't forget about treatment. Treatment works. All right, I'm just going to end on this last slide here to say thank you, thank you, thank you. Make sure you are ordering and offering those vaccines in your clinics. Your voice matters. Your recommendation is particularly powerful here. So really appreciate everything that you're doing to facilitate conversations with your patients, to recommend those vaccines, to set it up into your workflow, and again, offer early treatment for COVID for patients at risk. I'm going to stop there, and I'm going to bring in the amazing Dr. Patel and Dr. Daskalakis, who have been doing the hard work on this all along, who will be helping answer your questions. So back over to you, Dr. Scott.
Well, thank you, Dr. Cohen, for your opening remarks. And we already have a number of questions, so let's move into the Q&A portion. Let's start with some of the questions that were submitted during the registration. The first question is for you, Dr. Cohen. Are we expecting an earlier or more severe respiratory season this year?
Thanks for the question on that. So one of the ways in which we try to get a little bit of a sense of what's going to happen for our flu season or our overall respiratory season is to look at the southern hemisphere where flu is circulating right now. And what we, again, it's never a perfect marker, but what we are seeing, it's a pretty typical season, meaning it didn't start too early, where they're seeing what is a pretty typical season. So not better, not worse, but pretty typical, didn't start early. So again, we're anticipating a typical start, which means later in the October timeframe. However, we, coming out of the COVID pandemic, we are still recalibrating what the start times of these seasons are. So we want to be prepared now. That's why we're here at the beginning of August having this conversation to get ready, get prepared as we get into the season. We have the power in our own hands to know how bad of a season it's going to be, right? The more protection we get out there, the more mild the season can be.
So our second question stays with you, Dr. Cohen. And I know you've mentioned some of this during your comments, but how do you recommend communicating with patients who have previously rejected vaccination or who have expressed hesitation about vaccines?
Well, I think this is such an important question. First, and I want to say, your patients best. So you are going to be the one best positioned to know how to approach the topic. We want to give you as many tools, right? Words, strong words that can help, but you need to know your patients best. What I would just recommend is don't take no as a final answer. Take it as a start of a conversation. Be open to answering those questions. I would also share what you are doing personally for yourself. I try to do that in the interviews that I do. I as I did earlier, shared what we're going to do for my own family, what I do personally. I think personalizing it is so powerful because you can give folks the stats. But when you talk about, well, this is what I would do for my own family, I think that's really important. And I do think that vaccine hesitancy is on a continuum. There are folks you're not going to reach, but there are a lot of folks who just need some questions answered. They want to hear that you're recommending it to them. So again, figure out where your patient is on that continuum. Make sure that it's not a binary yes, no, but it's an opportunity to answer questions and that you feel like you have the information you need. And a lot of that is on CDC sites. AMA is promoting that information, but make sure you have the tools you need, as well as your staff has the tools that they need to be answering questions. Because it's not just the doctor at the end coming in. It is all along the way, right? From check-in process to throughout that visit are opportunities to get patients ready to be vaccinated.
Okay, another question for you, Dr. Cohen. Why is CDC changing RSV vaccine recommendations for older adults after new recommendations were made just last year?
Well, we always look at the data to make sure that our recommendations are both clear and that they are actionable based on the data that we are seeing. So we had some new real-world evidence around older adults, and that showed the effectiveness. So we wanted to be very clear that those who over 75 should get an RSV vaccine. So 75 plus, get the vaccine. And we wanted that language to be even more clear. And we made the language more clear for those 60 to 74 with high risk conditions as we went through. So again, that's a matter of us, incorporating that new data and being clear on what we think will protect folks.
So our next question actually is for Dr. Daskalakis. This question comes from a physician who says, I have a patient or patients who are 60 to 74 years old. They have medical conditions or risk factors, and I think this puts them at risk for severe RSV disease, but which aren't specifically listed as the high-risk conditions. Can they still receive RSV vaccine?
Thank you, Dr. Scott, and for the physician who put in that question. So first, I'll start with the plug. Just now published is the MMWR, the Morbidity and Mortality Weekly Report that actually summarizes all of the recommendations around RSV. So just published as we speak. So the short answer is clinical acumen counts. So yes, that provider is able to make that decision based on their own feeling and interpretation and data they have on the patient. So the recommendations state that adults who are 60 to 74 can receive the vaccine if they have any other chronic medical conditions or risk factors that a healthcare provider determines would increase the risk of severe disease due to any respiratory viral infection. And so just sort of stepping back for a moment, examples of other risk factors that could be considered is that person someone that you're deeming as frail? That may increase their risk of respiratory disease. Is there a situation where you may think that there are undiagnosed chronic medical conditions? Again, that would be a great reason to give the RSV vaccine. And for people in that 60 to 74 range, I think a real consideration for folks who are living in a rural community is if they're far enough away from where they can access healthcare, then it's a really good idea to provide them that RSV vaccine. So again, guidelines are guidelines and clinical acumen plays in. So really, as Dr. Cohen said, you know your patient's best and use that knowledge to make decisions about recommending RSV vaccine in that 60 to 74-year-old range. Thank you.
So let's go to Dr. Patel for this next question. This season, we will again have multiple options to prevent severe RSV in infants. How should we counsel patients about receiving the maternal RSV vaccine versus waiting for the monoclonal antibody for their newborn?
Right. We now have not one, but 2 immunizations that protect infants against severe RSV, the leading cause of hospitalization in the United States for infants, like Dr. Cohen said. And last season, about 50% of eligible infants were protected, either through the maternal RSV vaccine or through nirsevimab. It's just a really great achievement, given that this was the first year that these immunizations were available, and a strong testament to all of you as providers making those strong recommendations for those patients. So we've had another year of data, and in terms of effectiveness, both of these products provide substantial protection for infants against severe RSV. And then in terms of safety, no unexpected signals flagging in our safety surveillance ecosystem, which both CDC and FDA contribute to. So we don't have a preference in terms of which product or immunization should be chosen over the other. Both are really great options. But to your question is, well, then how do you choose? And it comes down to 2 immunization pieces. Number 1, access, and number 2, acceptance. And so when we think about access, one of the key things that patients think about when they're making their choice is convenience. And so carrying those immunizations in your clinic, like Dr. Cohen said, is just really critical. It makes it easier for patients to make that choice. Now, if you don't have either maternal RSV vaccine or nirsevimab in your clinic, know where to go. And just a reminder that for maternal RSV vaccine, it is only Pfizer's Abrysvo that is licensed and recommended for pregnant people. And if you're a birthing hospital, knowing where in your local community nirsevimab, which providers may be carrying nirsevimab, is also really important. And then acceptance, and this really is about patient preference. Now, maternal immunization provides immediate protection right when the infant is born, and that's a really important consideration for the patient as well as the provider, especially if you're concerned that the infant may have a delayed linkage to care after birth. The other part is that the patient or the mom may prefer that the infant gets nirsevimab after the baby is born. Now, the footnote there is that there may be clinical reasons or medical conditions that would a provider may prefer that the patient get not get maternal RSV vaccine, and those are things like weakened immune conditions that sort of delay or reduce the transfer of placental antibodies. So it's always important to know your patient, and you all know them best. So in summary, two things. Number one is have those conversations early with your patients before 32 weeks gestation, so you know what the plan is. And number two, know where you're going to send your patients once you make that decision.
Well, thank you, Dr. Patel. We have a couple more questions here for Dr. Cohen. The first one is, are there other potential threats on the horizon, including avian influenza, commonly known as bird flu, which has recently jumped to humans in a small number of cases? How concerned should we be about bird flu, and what steps should primary care physicians be taking at this point, including vaccination?
Great. Thanks, Dr. Scott. I appreciate being able to address avian flu, but for the vast majority of primary care docs, the risk in your patient population is extremely low. If you happen to work with folks who work on farms or have come into contact with cows or with poultry, you definitely want to have that as a heightened thing that you are looking for. But we have not seen a case of human to human spread of avian flu. And that is good news, but we are taking this very seriously. We do know that farm workers are at risk and those who are exposed to the avian virus directly, but the larger population, the risk is very low. That all being said, I think it makes it even more important that we focus on getting folks the seasonal flu vaccine this year. We want to make sure folks have as much flu coverage as we can, right, to protect folks against the known thing that is spreading human to human, and that is seasonal flu. But we are working very hard to make sure we are protecting workers, that there is testing available. It is a very different circumstance with avian flu than for COVID, for example. Avian flu is something we have known about and been studying and preparing for decades. We have tests, we have treatment that is Tamiflu, and we even have vaccine candidates. So if we would see any escalation in what is presenting right now, we could also think about a vaccination campaign for farm workers. Already. We have that available. So we have a lot of tools at our disposal, but for general folks in primary care, if you're not working with the farm community, that is unlikely to be something that you are seeing, but I do think it puts a bigger emphasis on us wanting to get both seasonal vaccinations for folks as well as our farm worker community.
Dr. Cohen, when diagnostic testing is not available, what are the best clinical indicators for choosing treatment for respiratory illness, for example, Paxlovid or also Tomavir?
Well, we always want to do our best to differentiate what folks have, but that might not always be the reality that we can get testing at the time we want, though we've made COVID testing very, very easy and over the counter and rapid tests. We have rapid flu tests, but that's not always possible when there are, a number of challenges we can all think about. And so it's really important to just know what's happening in your community and to take a good history, but we do not think that should stop you from empirically starting treatment, particularly for those who are at high risk. So right now, as we sit here in August, what is circulating in terms of respiratory virus is COVID, right? So there isn't a competition between COVID or flu and RSV. So right now, someone coming in who's over 65, higher risk, empirically starting Paxlovid to make sure that they're protected is absolutely something that we would want you to think about. Co-infection is possible, but pretty rare. So it is usually pretty rare. And so you want to be able to understand what is circulating in your community, differentiate the best you can, start empiric treatment, particularly for those who are high risk.
So staying with Dr. Cohen for one more question here, what should we be telling our patients about other ways to protect themselves? What is the current guideline for masking, and what about other healthcare professionals?
Yeah, really important, right? So we've been talking about everything we can do to prepare, but once we're in the season and once we think that there's a lot of virus circulating, that we've all learned through the pandemic about a lot of different tools that can help us to make sure that we are reducing our risk of getting those viruses circulating. So we, as you may know, we redid our guidance on this back in the spring. So at the end of the winter season, we looked at our data and said, and simplified our guidance on this. And we also simplified it to focus on the thing that we know saves the most lives, and that's vaccination. That's why we spent 90% of our time on this webinar talking about vaccination. It's what works, it what keeps people out of the hospital, it's what saves lives. But there are other ways we can also do things to protect ourselves. One is stay home when you're sick, right? And which I know is hard, to miss that family that family party or that thing, that work event, but keep your germs to yourself and stay home when you're sick. But if you are out doing things like hand sanitizing, wearing a mask, opening windows, improving ventilation. All of those are layers of protection, particularly if you are at higher risk or you are going to be around people who are at higher risk. You want to layer those things on top. So vaccination as a foundation, staying home if you're sick as a foundation, but then being outside, wearing a mask, using hand sanitizer, right? All of these things add layers of protection beyond that foundation. And this is the same guidance between COVID, flu, or RSV. It's across any of these viruses. We did have specific guidance for quite some time around COVID because COVID was something new to us as humans. We hadn't had previous immunity to it. Now that most of us have either had COVID, been vaccinated, we are different. The virus is still pretty transmissible, as we're seeing right now in the summer, but we are different, and that is good, meaning it is overall less severe than it was when we were first seeing the virus introduced to our communities. But it doesn't mean it's gone. And so we do have to remain vigilant. Again, vaccination, still the best tool here to protect lives as we go into the season.
So I'm going to shift over to Dr. Daskalakis for a moment to a different at-risk population. What are we doing to protect those in nursing homes?
Thanks again for that question, Dr. Scott. So I'll start by just saying that, it does definitely take a village. So it's not just CDC, but really our close collaboration with our long-term care partners, as well as our colleagues over at CMS, especially the Quality Improvement Networks. We've really been trying to do what we do best, which is listen and take that feedback into more actionable strategies. And so we've been listening to the feedback from nursing homes and from the providers that work in the nursing homes about respiratory vaccine access, as well as the challenges that they experience really at the front line to address uptake in the coming season. So one of the really important messages we heard loud and clear was the need for improved awareness around reimbursement process. So there have been a couple of different strategies that we've used, including at the end of May, CDC co-hosted a webinar with CMS to educate long-term care providers on respiratory virus vaccine payment procedures, and also shared experiences from quality improvement organizations to help them navigate really how to make sure that they're getting appropriately reimbursed. I'll also say that CMS released a billing guide last year that I think is really, really helpful in terms of how to bill for these vaccines. The other piece of this is data. So we know that having a really clear picture of what's happening at these long-term care facilities and to these populations is really what allows us to inform our actions and really nuance our approach to the response to making sure that we protect more people during the season. So with that in mind, CDC funded at AMDA, the Society for Post-Acute and Long-Term Care Medicine, which led the Moving Needles project that really was valuable in collecting data on a lot of topics, including data around immunization information systems, like what it's like at the nursing home or the long-term care facility, how that interacts with their electronic health record and how their systems integrate. And we're really using that data to look at vaccine attitude, access, and uptake for healthcare workers who are so critical. So though we're talking about long-term care residents, Also important for the people who take care of them to make sure that they are also up to date on their vaccines, since again, it is really a great strategy for protecting the residents to make sure that the staff are also vaccinated. So we also know from our National Healthcare Safety Network that as of July 7th, 2024, vaccination for long-term care facility patients was about 31% for COVID, 69% for flu, and 20% for RSV. Always room for improvement, which is why we're doing this today. Also, for providers that are listening, another plug is that even if you're not taking care of the patient in a long-term care facility, your patient may be someone who cares for someone who lives in a long-term care facility. So reinforcing for them the importance of vaccination, since often those caregivers are actually the decision makers for those patients in long-term care, really important. So I'll say ongoing information coming from the long-term care facilities and partners is going to be critical to make sure that we continue to have that visibility so we can really produce some products and resources that may help. But I'll just focus on a couple of them. So first is the one that Dr. Cohen already showed, which is that the one page that has all of the product information in one place. That comes directly from our feedback from long-term care facilities and pediatricians who have the exact same questions. So we put those together because of that. So definitely refer you there. Information from return policy all the way down to how many vials are in a minimum order. Additionally, we have a space to watch. We've heard from a lot of long-term care facility providers that the vaccine information statement, or VIS, is one way that they use to communicate risks and benefits of receiving a vaccine. And so we actually are supplementing that with an additional document that can be used in tandem that is more motivational to why it's important. So a lot of the things that you're hearing today on a piece of paper that will also go to either the caregiver, the patient, or the provider around these vaccines. So we're not done. We have more work to do, and these channels are open. We'll keep getting feedback during this season. And as Dr. Cohen said, our goal is to make this better and better every season, since it happens every year. Dr. Scott, I'll hand it back to you.
Thank you. We're running a little short on time, but I've heard this next question myself with my patients. What are the current recommendations for co-administering COVID-19, flu, and RSV vaccines?
So then I'll keep it short to make sure that we can get to more questions. Bottom line is that's a best practice. So co-administering these vaccines is really critical, especially for people where you only have one shot at getting them. It is safe. We know that we have a long history of sort of COVID and flu co-administration, and the data also supports the safety of co-administration of RSV vaccines at the same time. And also not only from the safety perspective, but it doesn't seem to blunt the immunologic response to any of the vaccines. So again, if you have someone in front of you and the option is, this is my chance to give them vaccines, this is what co-administration is a best practice, so we encourage it. Thanks.
So let me stay with you for a moment to ask you about another population. Those who have recently recovered from COVID-19, should they receive the 24-25 COVID-19 vaccine?
Great question, and we get that one all the time. So I think, I think that as if an individual is diagnosed with COVID, whether they're symptomatic or have a positive test, the recommendation is that they can consider delaying their next dose of COVID-19 vaccine for about 3 months. That's a great conversation to have with your clinician as well. But generally, it is about 3 months after the positive test or from symptom onset.
So let's switch quickly over to Dr. Patel for a couple questions. Dr. Patel, can a pregnant patient receive an RSV vaccine at a pharmacy if the physicians are not able to stock the vaccine in their clinic?
Yeah, so of course, the first thing is to go back to, can we stock the vaccines? It's more convenient for the patient. It increases that vaccine coverage rate. But if they can't, then yes, pharmacies are actually stocking RSV vaccines, but there are a couple of things that we can do to make that easier. So number one is making sure which local pharmacies I had mentioned earlier are carrying that Pfizer Abrysvo vaccine, because that's the only one that's licensed and recommended for pregnant patients. Number two, just check what the requirements are for prescriptions. Most states don't require a prescription, but your state may. And third is just documenting everything. And you can give that piece of paper to your patient, whether that's in a prescription or an order or the after visit summary. Dr. Cohen covered this as well, is writing down the indication and helping to close that care loop. So it is Pfizer or Brisvo. That's the one thing we want to put on there. Number two, the pregnancy status. And the gestational age. And it might help actually to write the dates in which that patient is 32 to 36 weeks pregnant.
So let's do one more question for you, Dr. Patel. Clinically, what is the rationale for the January 31st cutoff for the maternal RSV vaccination in most of the continental United States?
Yeah, we've gotten this question quite a bit as well. And remember, the number one thing we want to do is protect these infants when they're at highest risk, which is when we have seasonal RSV activity, typically the fall and winter in most of the continental United States. And so if you were to vaccinate a pregnant mom in February, that infant won't be born until March or April. And typically in the United States, that's not going to be a lot of RSV circulation. So what we would prefer to do is actually give that infant nirsevimab in October. If a baby is born in March, there'll be 7 months in October, still eligible for nirsevimab, and that will protect him through that second season when there's more RSV activity.
Well, thank you very much. And these have been great questions. I have more questions, but we're running out of time. I want to go back to Dr. Cohen. And before we close, give you the opportunity for the last word. What can we do to keep our patients safe during this upcoming fall-winter respiratory virus season?
Well, first, Dr. Scott, just a big thank you to you, to AMA, to First Line for having this event, and to everyone who has joined and taking the time to prepare now ahead of the respiratory virus season, thinking about pre-ordering, about how you're going to talk about this with your patients, knowing who is able to get what, because increasing vaccination rates is a team sport, and making sure that folks feel trust in vaccines is a team sport. So again, just reminding you that it's not just you personally as the prescriber, but it's everyone on your team. Think about how they could be champions for vaccination, making sure that you're getting it into the workflow. Make it easy for your patients to get vaccinated by stocking those vaccines. Order now, order ahead of time, so you'll have them in your office. And then use some of the communication guides. Those can be hard conversations. We recognize that, but it's really important to make that strong recommendation. Be open to questions, and make sure this can be a dialogue. It might not be that the person says yes on that visit. Come back to it the next visit. Particularly for our higher risk patients, they're in your office more often because we're checking up on their chronic conditions. So there's going to be multiple bites of the apple this season for those patients, and make sure that you ask them at every visit, and be personal about this. We all, we're scientists. We want to bring the data, but telling folks about what you do personally for yourself, for your family, I think can also bridge gaps and build trust here. So again, just thank you so much for everything you're doing. Thank you to Dr. Patel and Dr. Daskalakis, who are amazing, brilliant, and doing terrific work with the whole team. And again, thank you to you, Dr. Scott.
Well, thank you. And as we close out today's discussion, I want to also thank Dr. Patel and Dr. Daskalakis, as well as you, Dr. Mandy Cohen, for joining us and providing such valuable insights on how we as healthcare professionals can protect our patients and their families this fall and winter during this respiratory season. I also want to thank everyone who joined today's call for your questions and for your interest in this important topic. A recording of this webinar will be available on this page shortly. In this tab, you will also find a PDF with instructions on how to obtain CE through the CDC Train. You can search for this course also in the course catalog using WC4847-080624. That number again, WC4847-080624. This course also has an access code of CDC-AMA 2024. The AMA will continue to partner with our colleagues at the CDC try to ensure that we're doing all that we can to protect the health and the health care of professionals, our patients, and our families. If you want to know more about the AMA's work with Project First Line, I encourage you to visit amafirstline.org. Thank you and stay well.